Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine. Hi, This Week in Medicine, we will be discussing. First, we will be discussing articles in New England Journal of Medicine. Overall survival with adjuvant pembrolizumab in renal cell carcinoma. Background: Adjuvant pembrolizumab therapy after surgery for renal cell carcinoma was approved on the basis of a significant improvement in disease-free survival in the Keynote 564 trial. Whether the results regarding overall survival from the third pre-specified interim analysis of the trial would also favor pembrolizumab was uncertain. Methods: In this Phase 3, double-blind, placebo-controlled trial, we randomly assigned, in a 1-to-1 ratio, participants with clear cell renal cell carcinoma who had an increased risk of recurrence after surgery to receive pembrolizumab, at a dose of 200 mg, or placebo every 3 weeks for up to 17 cycles, approximately 1 year, or until recurrence, the occurrence of unacceptable toxic effects, or withdrawal of consent. A significant improvement in disease-free survival according to investigator assessment, the primary endpoint, was shown previously. Overall survival was the key secondary endpoint. Safety was a secondary endpoint. Results: A total of 496 participants were assigned to receive pembrolizumab and 498 to receive placebo. As of September 15, 2023, the median follow-up was 57.2 months. The disease-free survival benefit was consistent with that in previous analyses. Hazard ratio for recurrence or death, 0.72, 95% confidence interval, c. 0.59 to 0.87. A significant improvement in overall survival was observed with pembrolizumab as compared with placebo. Hazard ratio for death, 0.62. 95% C, 0.44 to 0.87, p equals 0.005. The estimated overall survival at 48 months was 91.2% in the pembrolizumab group, as compared with 86.0% in the placebo group. The benefit was consistent across key subgroups. Pembrolizumab was associated with a higher incidence of serious adverse events of any cause, 20.7%, versus 11.5% with placebo, and of grade 3 or 4 adverse events related to pembrolizumab or placebo, 18.6% versus 1.2%. No deaths were attributed to pembrolizumab therapy. Conclusions: Adjuvant pembrolizumab was associated with a significant and clinically meaningful improvement in overall survival, as compared with placebo, among participants with clear cell renal cell carcinoma at increased risk for recurrence after surgery. Beta blockers after myocardial infarction and preserved ejection fraction. Background: Most trials that have shown a benefit of beta blocker treatment after myocardial infarction included patients with large myocardial infarctions and were conducted in an era before modern biomarker-based diagnosis of myocardial infarction and treatment with percutaneous coronary intervention, antithrombotic agents, high-intensity statins, and renin-angiotensin-aldosterone system antagonists. Methods: In a parallel group, open-label trial performed at 45 centers in Sweden, Estonia, and New Zealand, we randomly assigned patients with an acute myocardial infarction who had undergone coronary angiography and had a left ventricular ejection fraction of at least 50% to receive either long-term treatment with a beta blocker, metoprolol or bisoprolol, or no beta blocker treatment. The primary endpoint was a composite of death from any cause or new myocardial infarction. Results: From September 2017 through May 2023, a total of 5,020 patients were enrolled, 95.4% of whom were from Sweden. The median follow-up was 3.5 years, interquartile range, 2.2 to 4.7. A primary endpoint event occurred in 199 of 2,508 patients, 7.9%, in the beta blocker group and in 208 of 2,512 patients, 8.3%, in the no beta blocker group, Hazard ratio 0.96, 95% confidence interval 0.79 to 1.16, p equals 0.64. Beta blocker treatment did not appear to lead to a lower cumulative incidence of the secondary endpoints, death from any cause, 3.9% in the beta blocker group and 4.1% in the no beta blocker group, death from cardiovascular causes, 1.5% and 1.3%, respectively, myocardial infarction, 4.5% and 4.7%, hospitalization for atrial fibrillation, 1.1% and 1.4%, and hospitalization for heart failure, 0.8% and 0.9%. With regard to safety endpoints, hospitalization for bradycardia, second or third degree atrioventricular block, hypotension, syncope, or implantation of a pacemaker occurred in 3.4% of the patients in the beta blocker group, and in 3.2% of those in the no beta blocker group, hospitalization for asthma or chronic obstructive pulmonary disease in 0.6% and 0.6%, respectively, and hospitalization for stroke in 1.4% and 1.8%. Conclusions. Among patients with acute myocardial infarction who underwent early coronary angiography and had a preserved left ventricular ejection fraction, greater than or equal to 50%, long-term beta blocker treatment did not lead to a lower risk of the composite primary endpoint of death from any cause or new myocardial infarction than no beta blocker use. Microaxial flow pump or standard care in infarct-related cardiogenic shock. Background. The effects of temporary mechanical circulatory support with a microaxial flow pump on mortality among patients with ST segment elevation myocardial infarction, STEMI, complicated by cardiogenic shock remains unclear. Methods. In an international, multi-center, randomized trial, we assigned patients with STEMI and cardiogenic shock to receive a microaxial flow pump, Impella CP, plus standard care or standard care alone. The primary endpoint was death from any cause at 180 days. A composite safety endpoint was severe bleeding, limb ischemia, hemolysis, device failure, or worsening aortic regurgitation. Results. A total of 360 patients underwent randomization, of whom 355 were included in the final analysis, 179 in the microaxial flow pump group and 176 in the standard care group. The median age of the patients was 67 years and 79.2% were men. Death from any cause occurred in 82 of 179 patients, 45.8%, in the microaxial flow pump group and in 103 of 176 patients, 58.5%, in the standard care group. Hazard ratio, 0.74, 95% confidence interval, c. 0.55 to 0.99, p equals 0.04. A composite safety endpoint event occurred in 43 patients, 24.0%, in the microaxial flow pump group and in 11, 6.2%, in the standard care group. Relative risk, 4.74, 95% c. 2.36 to 9.55. Renal replacement therapy was administered to 75 patients, 41.9%, in the microaxial flow pump group, and to 47 patients, 26.7%, in the standard care group. Relative risk, 1.98, 95% c. 1.27 to 3.09. Conclusions. The routine use of a microaxial flow pump with standard care in the treatment of patients with STEMI-related cardiogenic shock led to a lower risk of death from any cause at 180 days than standard care alone. The incidence of a composite of adverse events was higher with the use of the microaxial flow pump. Semaglutide in patients with obesity-related heart failure and type 2 diabetes. Background. Obesity and type 2 diabetes are prevalent in patients with heart failure with preserved ejection fraction and are characterized by a high symptom burden. No approved therapies specifically target obesity-related heart failure with preserved ejection fraction in persons with type 2 diabetes. Methods. We randomly assigned patients who had heart failure with preserved ejection fraction, a body mass index, the weight in kilograms divided by the square of the height in meters, of 30 or more, and type 2 diabetes to receive once-weekly semaglutide, 2.4 milligrams, or placebo for 52 weeks. The primary endpoints were the change from baseline in the Kansas City Cardiomyopathy Questionnaire Clinical Summary Score, KCCQ-CSS. Scores range from 0 to 100, with higher scores indicating fewer symptoms and physical limitations, and the change in body weight. Confirmatory secondary endpoints included the change in 6-minute walk distance, a hierarchical composite endpoint that included death, heart failure events, and differences in the change in the KCCQ-CSS and 6-minute walk distance, and the change in the C-reactive protein, CRP, level. Results. A total of 616 participants underwent randomization. The mean change in the KCCQ-CSS was 13.7 points with semaglutide and 6.4 points with placebo, estimated difference, 7.3 points, 95% confidence interval, C, 4.1 to 10.4, p less than 0.001, and the mean percentage change in body weight was minus 9.8% with semaglutide and minus 3.4% with placebo, estimated difference, minus 6.4 percentage points, 95% C, minus 7.6 to minus 5.2, p less than 0.001. The results for the confirmatory secondary endpoints favored semaglutide over placebo, estimated between group difference in change in 6-minute walk distance, 14.3 meters, 95% C, 3.7 to 24.9, p equals 0.008, win ratio for hierarchical composite endpoint, 1.58, 95% C, 1.29 to 1.94, p less than 0.001, and estimated treatment ratio for change in CRP level, 0.67, 95% C, 0.55 to 0.80, p less than 0.001. Serious adverse events were reported in 55 participants, 17.7%, in the semaglutide group and 88, 28.8%, in the placebo group. Conclusions. Among patients with obesity-related heart failure with preserved ejection fraction and type 2 diabetes, semaglutide led to larger reductions in heart failure-related symptoms and physical limitations and greater weight loss than placebo at 1 year. Next, we will be discussing articles from Journal of American Medical Association. Serious bleeding in patients with atrial fibrillation using Diltiazem with Apixaban or Rivaroxaban. Importance: Diltiazem, a commonly prescribed ventricular rate control medication for patients with atrial fibrillation, inhibits Apixaban and Rivaroxaban elimination, possibly causing over-anticoagulation. Objective: to compare serious bleeding risk for new users of Apixaban or Rivaroxaban with atrial fibrillation treated with Diltiazem or metoprolol. Design, setting, and participants. This retrospective cohort study included Medicare beneficiaries aged 65 years or older with atrial fibrillation who initiated Apixaban or Rivaroxaban use and also began treatment with Diltiazem or metoprolol between January 1, 2012, and November 29, 2020. Patients were followed up to 365 days through November 30, 2020. Data were analyzed from August 2023 to February 2024. Exposures: Diltiazem and metoprolol. Results: the study included 204,155 U.S. Medicare beneficiaries, of whom 53,275 received Diltiazem and 150,880 received metoprolol. Study patients: mean SD, age 76.9, 7.0 years, 52.7% female, had 9,927 person-years pi of follow-up, median 120, IQR 59 to 281 days. Patients receiving Diltiazem treatment had increased risk for the primary outcome, RD 10.6, 95% C, 7.0 to 14.2, per 1,000 pi, HR 1.21, 95% C, 1.13 to 1.29, and its components of bleeding-related hospitalization, RD 8.2, 95% C, 5.1 to 11.4, per 1,000 pi, HR 1.22, 95% C, 1.13 to 1.31, and death with recent evidence of bleeding, RD 2.4, 95% C, 0.6 to 4.2, per 1,000 pi, HR 1.19, 95% C, 1.05 to 1.34, compared with patients receiving metoprolol. Risk for the primary outcome with initial diltiazem doses exceeding 120 mg/d, RD, 15.1, 95% C, 10.2 to 20.1, per 1000 pi, HR, 1.29, 95% C, 1.19 to 1.39, was greater than that for lower doses, RD, 6.7, 95% C, 2.0 to 11.4, per 1000 pi, HR, 1.13, 95% C, 1.04 to 1.24. For doses exceeding 120 mg/d, the risk of major ischemic or hemorrhagic events was increased, HR, 1.14, 95% C, 1.02 to 1.27. Neither dose group had significant changes in the risk for ischemic stroke or systemic embolism or death without recent evidence of bleeding. When patients receiving high and low dose diltiazem treatment were directly compared, the HR for the primary outcome was 1.14, 95% C, 1.02 to 1.26. Conclusions and relevance in Medicare patients with atrial fibrillation receiving Apixaban or Rivaroxaban, diltiazem was associated with greater risk of serious bleeding than metoprolol, particularly for diltiazem doses exceeding 120 mg/d. Non-high-density lipoprotein cholesterol levels from childhood to adulthood and cardiovascular disease events. Importance: elevated non-high-density lipoprotein cholesterol, non-HDL-C, a recommended measure of lipid-related cardiovascular risk, is common in children and increases risk of adult cardiovascular disease, CVD. Whether resolution of elevated childhood non-HDL-C levels by adulthood is associated with reduced risk of clinical CVD events is unknown. Objective: to examine the associations of non-HDL-C status between childhood and adulthood with incident CVD events. Design, setting, and participants. Individual participant data from 6 prospective cohorts of children, mean age at baseline, 10.7 years, in the US and Finland. Recruitment took place between 1970 and 1996, with a final follow-up in 2019. Exposures: child, age 3 to 19 years, and adult, age 20 to 40 years, non-HDL-C age and sex-specific Z-scores and categories according to clinical guideline recommended cutoffs for dyslipidemia. Main outcomes and measures: incident fatal and non-fatal CVD events adjudicated by medical records. Results: over a mean length of follow-up of 8.9 years after age 40 years, 147 CVD events occurred among 5,121 participants, 60% women, 15% Black. Both childhood and adult non-HDL-C levels were associated with increased risk of CVD events. Hazard ratio, HR, 1.42, 95% C, 1.18 to 1.70, and HR, 1.50, 95% C, 1.26 to 1.78, for a 1-unit increase in Z-score, respectively, but the association for childhood non-HDL-C was reduced when adjusted for adult levels. HR, 1.12, 95% C, 0.89 to 1.41. A complementary analysis showed that both childhood non-HDL-C levels and the change between childhood and adulthood were independently associated with the outcome, suggesting that from a preventive perspective, both childhood non-HDL-C levels and the change into adulthood are informative. Compared with those whose non-HDL-C levels remained within the guideline recommended range in childhood and adulthood, participants who had incident non-HDL-C dyslipidemia from childhood to adulthood and those with persistent dyslipidemia had increased risks of CVD events. HR, 2.17, 95% C, 1.00 to 4.69, and HR, 5.17, 95% C, 2.80 to 9.56, respectively. Individuals who had dyslipidemic non-HDL-C in childhood but whose non-HDL-C levels were within the guideline recommended range in adulthood did not have a significantly increased risk. HR, 1.13, 95% C, 0.50 to 2.56. Conclusions and relevance: individuals with persistent non-HDL-C dyslipidemia from childhood to adulthood had an increased risk of CVD events, but those in whom dyslipidemic non-HDL-C levels resolve by adulthood have similar risk to individuals who were never dyslipidemic. These findings suggest that interventions to prevent and reduce elevated childhood non-HDL-C levels may help prevent premature CVD. Next, we will be discussing articles from Annals of Internal Medicine. Deep Learning to Estimate Cardiovascular Risk from Chest Radiographs, a Risk Prediction Study. Background: Guidelines for Primary Prevention of Atherosclerotic Cardiovascular Disease, ASCADE, recommend a risk calculator, ASCADE risk score, to estimate 10-year risk for major adverse cardiovascular events, MACE. Because the necessary inputs are often missing, complementary approaches for opportunistic risk assessment are desirable. Objective: to develop and test a deep learning model, CXR-CVD risk, that estimates 10-year risk for MACE from a routine chest radiograph, CXR, and compare its performance with that of the traditional ASCADE risk score for implications for statin eligibility. Design: Risk Prediction Study. Setting: outpatients potentially eligible for primary cardiovascular prevention. Participants: the CXR-CVD risk model was developed using data from a cancer screening trial. It was externally validated in 8,869 outpatients with unknown ASCADE risk because of missing inputs to calculate the ASCADE risk score, and in 2,132 outpatients with known risk whose ASCADE risk score could be calculated. Measurements: 10-year MACE predicted by CXR-CVD risk versus the ASCADE risk score. Results: among 8,869 outpatients with unknown ASCADE risk, those with a risk of 7.5% or higher as predicted by CXR-CVD risk, had a higher 10-year risk for MACE after adjustment for risk factors, adjusted hazard ratio, HR, 1.73, 95% C, 1.47 to 2.03. In the additional 2,132 outpatients with known ASCADE risk, CXR-CVD risk predicted MACE beyond the traditional ASCADE risk score, adjusted HR, 1.88, C, 1.24 to 2.85. Limitation: retrospective study design using electronic medical records. Conclusion: on the basis of a single CXR-CVD risk predicts 10-year MACE beyond the clinical standard and may help identify individuals at high risk whose ASCADE risk score cannot be calculated because of missing data. Next, we will be discussing articles from Nature Medicine. Development and validation of a new algorithm for improved cardiovascular risk prediction. CRISC algorithms use data from millions of people to help clinicians identify individuals at high risk of cardiovascular disease, CVD. Here, we derive and externally validate a new algorithm, which we have named QR4, that incorporates novel risk factors to estimate 10-year CVD risks separately for men and women. Health data from 9.98 million and 6.79 million adults from the United Kingdom were used for derivation and validation of the algorithm, respectively. Cause-specific Cox models were used to develop models to predict CVD risk, and the performance of QR4 was compared with version 3 of CRISC, Systematic Coronary Risk Evaluation 2, SCORE 2, and Atherosclerotic Cardiovascular Disease, ASCADE, risk scores. We identified 7 novel risk factors in models for both men and women: brain cancer, lung cancer, Down syndrome, blood cancer, chronic obstructive pulmonary disease, oral cancer, and learning disability, and 2 additional novel risk factors in women: preeclampsia and postnatal depression. On external validation, QR4 had a higher C statistic than CRISC3 in both women, 0.835, 95% confidence interval, C 0.833 to 0.837, and 0.831, 95% C, 0.829 to 0.832, for QR4 and CRISC3, respectively, and men 0.814, 95% C, 0.812 to 0.816, and 0.812, 95% C, 0.810 to 0.814, for QR4 and CRISC3, respectively. QR4 was also more accurate than the ASCADE and SCORE2 risk scores in both men and women. The QR4 risk score identifies new risk groups and provides superior CVD risk prediction in the United Kingdom compared with other international scoring systems for CVD risk. Next, we will be discussing articles from British Medical Journal. Temporal trends in lifetime risks of atrial fibrillation and its complications between 2000 and 2022, Danish, nationwide, population-based cohort study. Objectives to examine how the lifetime risks of atrial fibrillation and of complications after atrial fibrillation changed over time. Design Danish, nationwide, population-based cohort study. Setting population of Denmark from January 1, 2000 to December 31, 2022. Participants 3.5 million individuals, 51.7% women and 48.3% men, who did not have atrial fibrillation at 45 years of age or older were followed up until incident atrial fibrillation, microaxial, death, or end of follow-up, whichever came first. All 362,721 individuals with incident atrial fibrillation, 46.4% women and 53.6% men, but with no prevalent complication, were further followed up until incident heart failure, stroke, or myocardial infarction. Main outcome measures lifetime risk of atrial fibrillation and lifetime risks of complications after atrial fibrillation over two pre-specified periods, 2010 v 2011-22. Results: the lifetime risk of atrial fibrillation increased from 24.2% in 2010 to 30.9% in 2011-22, difference 6.7%. 95% confidence interval 6.5% to 6.8%. After atrial fibrillation, the most frequent complication was heart failure with a lifetime risk of 42.9% in 2010 and 42.1% in 2011-22, minus 0.8%, minus 3.8% to 2.2%. Individuals with atrial fibrillation lost 14.4 years with no heart failure. The lifetime risks of stroke and of myocardial infarction after atrial fibrillation decreased slightly between the two periods, from 22.4% to 19.9% for stroke, minus 2.5%, minus 4.2% to minus 0.7%, and from 13.7% to 9.8% for myocardial infarction, minus 3.9%, minus 5.3% to minus 2.4%. No evidence was reported of a differential decrease between men and women. Conclusion: lifetime risk of atrial fibrillation increased over 2 decades of follow-up. In individuals with atrial fibrillation, about 2 in 5 developed heart failure and 1 in 5 had a stroke over their remaining lifetime after atrial fibrillation diagnosis, with no or only small improvement over time. Stroke risks and heart failure prevention strategies are needed for people with atrial fibrillation. Next, we will be discussing articles from Lancet. Patient, family caregiver, and economic outcomes of an integrated screening and novel step collaborative care intervention in the oncology setting in the USA, CARES, a randomized, parallel, phase 3 trial. Background: the current standard of care of screening and referring patients for treatment for symptoms, such as depression, pain, and fatigue, is not effective. This trial aimed to test the efficacy of an integrated screening and novel step collaborative care intervention versus standard of care for patients with cancer and at least one of the following symptoms: depression, pain, or fatigue. Methods: this randomized, parallel, phase 3 trial was conducted in 29 oncology outpatient clinics associated with the UPMC Hillman Cancer Center in the USA. Patients, age greater than or equal to 21 years, with any cancer type and clinical levels of depression, pain, or fatigue, or all of these, were eligible. Eligible family caregivers were aged 21 years or older and providing care to a patient diagnosed with cancer who consented for this study. Patients were randomly assigned, 1-to-1, to step collaborative care or standard of care using a central, permuted block design, sizes of 2, 4, and 6, stratified by sex and prognostic status. The biostatistician, oncologists, and outcome assessors were masked to treatment assignment. Step collaborative care was once-weekly cognitive behavioral therapy for 50 to 60 minutes from a care coordinator via telemedicine, e.g., telephone or video conferencing. Findings: between December 5, 2016, and April 8, 2021, 459 patients and 190 family caregivers were enrolled. 222 patients were assigned to standard of care and 237 to step collaborative care. Of 459 patients, 201, 44%, were male and 258, 56%, were female. Patients in the STEP collaborative care group had a greater 0.6-month improvement in health-related quality of life than patients in the standard of care group, p equals 0.013, effect size 0.09. Health-related quality of life was maintained for the STEP collaborative care group, p equals 0.74, effect size 0.01. Patients in the STEP collaborative care group had greater 0.6-month improvements than the standard of care group in emotional, p equals 0.012, functional, p equals 0.042, and physical, p equals 0.033, well-being. No adverse events were reported by patients in either group and deaths were considered unrelated to the study. Interpretation: an integrated screening and novel STEP collaborative care intervention, compared with the current standard of care, is recommended to improve health-related quality of life. The findings of this study will advance the implementation of guideline concordant care, screening and treatment, and has the potential to shift the practice of screening and treatment paradigm nationwide, improving outcomes for patients diagnosed with cancer. Next, we will be discussing articles from Journal of Clinical Oncology. Phase 3, randomized study of atezolizumab plus bevacizumab and chemotherapy in patients with EGFR or ALK mutated non-small cell lung cancer, Atlas, KCSG LU 1904 purpose. In the treatment of non-small cell lung cancer, NSCLC, with a driver mutation, the role of anti-PD-L1 antibody after tyrosine kinase inhibitor, TKI, remains unclear. This randomized, open-label, multi-center, Phase 3 study evaluates the efficacy of atezolizumab plus bevacizumab, paclitaxel, and carboplatin, ABCP, in EGFR or ALK mutated NSCLC that progressed before TKI therapy. Materials and methods. We compared the clinical efficacy of ABCP followed by maintenance therapy with atezolizumab plus bevacizumab with pemetrexed plus carboplatin or cisplatin, PC, followed by pemetrexed maintenance. The primary endpoint was progression-free survival, PFS. Results. A total of 228 patients with activating EGFR mutation, N equals 215, or ALK translocation, N equals 13, were enrolled from 16 sites in the Republic of Korea and randomly assigned at 2:1 ratio to either ABCP, N equals 154, or PC arm, N equals 74. The median follow-up duration was 26.1 months, 95% C, 24.7 to 28.2. Objective response rates, 69.5% B, 41.9%, P less than 0.001, and median PFS, 8.48 v 5.62 months, hazard ratio, HR, 0.62, 95% C, 0.45 to 0.86, P equals 0.004, were significantly better in the ABCP than PC arm. PFS benefit increased as PD-L1 expression increased, with an HR of 0.47, 0.41, and 0.24 for PD-L1 greater than or equal to 1%, greater than or equal to 10%, and greater than or equal to 50%, respectively. Overall survival was similar between ABCP and PC arm, 20.63 v 20.27 months, HR, 1.01, 95% C, 0.69 to 1.46, P equals 0.975. The safety profile of the ABCP arm was comparable with that previously reported, with no additional safety signals, but higher rates of treatment-related adverse events were observed compared with the PC arm. Conclusion. To our knowledge, this study is the first randomized Phase 3 study to demonstrate the clinical benefit of anti-PD-L1 antibody in combination with bevacizumab and chemotherapy in patients with EGFR or ALK mutated NSCLC who have progressed on relevant targeted therapy. Next, we will be discussing articles from Journal of Hepatology. Efficient formation and maintenance of humoral and CD4 T-cell immunity targeting the viral capsid in acute resolving hepatitis E infection. Background and aims. CD4 T-cells shape the neutralizing antibody, and AB response and facilitate viral clearance in various infections. Knowledge of their phenotype, specificity, and dynamics in hepatitis E virus (HEV) infection is limited. HEV is enterically transmitted as a naked virus, NEV, but acquires a host-derived quasi-envelope, AHEV, when budding from cells. While NEV is composed of the open reading frame, ORF2-derived capsid, AHEV particles also contain ORF3-derived proteins. We aim to longitudinally characterize the HEV-specific CD4 T cells targeting ORF1, 2 and 3 and antibodies against NEV or AHEV in immunocompetent individuals with acute and resolved HEV infection. Results: HEV-specific CD4 T cell frequencies and antibody titers are highest in individuals with acute infection and decline in a time-dependent process with an antigen hierarchy. HEV-specific CD4 T cells strongly target the ORF2-derived capsid. ORF3-specific CD4 T cells are hardly detectable. NAbs targeting HEV are found in high titers while AHEV particles are less efficiently neutralized. Capsid-specific CD4 T cells undergo memory formation and stepwise contraction, accompanied by dynamic phenotypical and transcriptional changes over time. Conclusion: the viral capsid is the main target of HEV-specific CD4 T cells and antibodies in acute resolving infection, correlating with efficient neutralization of NEV. Capsid-specific immunity rapidly emerges followed by a stepwise contraction several years after infection. Impact and implications: the interplay of CD4 T cells in neutralizing antibody responses is critical in the host defense against viral infections, yet little is known about their characteristics in hepatitis E virus (HEV) infection. We conducted a longitudinal study of immunocompetent individuals with acute and resolved HEV infection to understand the characteristics of HEV-specific CD4 T cells and neutralizing antibodies targeting different viral proteins and particles. We found that HEV-specific CD4 T cells mainly target capsid-derived epitopes. This correlates with efficient neutralization of naked virions while quasi-enveloped particles are less susceptible to neutralization. As individuals with pre-existing liver disease and immunocompromised individuals are at risk for fulminant or chronic courses of HEV infection, these individuals might benefit from the development of vaccination strategies which require a detailed knowledge of the composition and longevity of HEV-specific CD4 T cell and antibody immunity. A new clinical and prognostic characterization of the patterns of decompensation of cirrhosis. Background and aims. The prognostic impact of acute decompensation AD, i.e., the development of complications that require hospitalization, has recently been assessed. However, complications of cirrhosis do not necessarily require hospitalization and can develop progressively, as in the recently defined non-acute decompensation, NAD. Nevertheless, there is no data regarding the incidence and prognostic impact of NAD. The aim of the study was to evaluate the incidence and the prognostic impact of NAD at AD in outpatients with cirrhosis. Methods: a total of 617 outpatients with cirrhosis from 2 Italian tertiary centers, Padua and Milan, were enrolled from January 2003 to June 2021, and followed prospectively until the end of the study, death or liver transplantation. The complications registered during follow-up were considered as AD if they required hospitalization, or NAD if managed at the outpatient clinic. Results: during follow-up, 154 patients, 25.0% of total patients, developed complications, 69 patients, 44.8%, developed NAD, and 85, 55.2%, developed AD, while 29 patients with NAD, 42.0%, developed a further episode of AD during follow-up. 60-month survival was significantly higher in patients with no decompensation than in patients with NAD or AD. On multivariable analysis, AD, hazard ratio, HR, 21.07, p less than 0.001, NAD, HR 7.13, p less than 0.001, the etiological cure of cirrhosis, HR 0.38, p less than 0.001, and model for end-stage liver disease score, HR 1.12, p equals 0.003, were found to be independent predictors of mortality. Conclusions: The first decompensation is non-acute in almost 50% of outpatients, though such events are still associated with decreased survival compared to no decompensation. Patients who develop NAD must be treated with extreme care and monitored closely to prevent the development of AD. Impact and implications. This multicenter study is the first to investigate the role of non-acute decompensation, NAD, in patients with cirrhosis. In fact, while the unfavorable impact of acute decompensation is well known, there is currently a dearth of evidence on NAD, despite it being a common occurrence in clinical practice. Our data show that almost half of decompensations in patients with cirrhosis can be considered NAD and that such events are associated with a higher risk of mortality than no decompensation. This study has important clinical implications because it highlights the need to carefully consider patients who develop NAD, in order to prevent further decompensation and reduce mortality. Next, we will be discussing articles from Clinical Gastroenterology. Statins are associated with a decreased risk of severe liver disease in individuals with non-cirrhotic chronic liver disease. Background and aims. Little is known about the potential impact of statins on the progression of non-cirrhotic chronic liver diseases, CLDs, to severe liver disease. Methods. Using liver histopathology data in a nationwide Swedish cohort, we identified 3,862 non-cirrhotic individuals with CLD and statin exposure, defined as a statin prescription filled for 30 or more cumulative defined daily doses. Statin users were matched to 3,862, statin, non-users with CLD through direct 1-to-1 matching followed by propensity score matching. Cox regression was used to estimate hazard ratios, HRs, for the primary outcome of incident severe liver disease, a composite of cirrhosis, hepatocellular carcinoma, and liver transplantation/liver-related mortality. Results. A total of 45.3% of CLD patients had non-alcoholic fatty liver disease, 21.9% had alcohol-related liver disease, 17.7% had viral hepatitis, and 15.1% had autoimmune hepatitis. During follow-up evaluation, 234, 6.1%, statin users versus 276, 7.1%, non-users developed severe liver disease. Statin use was associated with a decreased risk of developing severe liver disease, HR, 0.60, 95% C, 0.48 to 0.74. Statistically significantly lower rates of severe liver disease were seen in alcohol-related liver disease, HR, 0.30, 95% C, 0.19 to 0.49, and in non-alcoholic fatty liver disease, HR, 0.68, 95% C, 0.45 to 1.00, but not in viral hepatitis, HR, 0.76, 95% C, 0.51 to 1.14, or autoimmune hepatitis, HR, 0.88, 95% C, 0.48 to 1.58. Statin use had a protective association in both prefibrosis and fibrosis stages at diagnosis. Statin use was associated with lower rates of progression to cirrhosis, HR, 0.62, 95% C, 0.49 to 0.78, hepatocellular carcinoma, HR, 0.44, 95% C, 0.27 to 0.71, and liver-related mortality, HR, 0.55, 95% C, 0.36 to 0.82. Conclusions. Among individuals with non-cirrhotic CLD, incident statin use was linked to lower rates of severe liver disease, suggesting a potential disease-modifying role. Accuracy of the enhanced liver fibrosis test in patients with type 2 diabetes mellitus and its clinical implications. Background and aims. The diagnostic performance of the Fibrosis-4, FIB-4, Index and Non-Alcoholic Fatty Liver Disease, NAFLD, Fibrosis Score, NFS, is poor in patients with type 2 diabetes mellitus, T2DM. We determined the usefulness of the Enhanced Liver Fibrosis, ELF, test in patients with T2DM. Methods. A total of 1,228 patients with biopsy-proven NAFLD were enrolled. The diagnostic performance of the ELF test for predicting advanced fibrosis in participants with or without T2DM was evaluated in comparison with the FIB-4 index and NFS. Results. Overall, the area under the curve of the ELF test for predicting advanced fibrosis was greater, 0.828, than that of the FIB-4 index, 0.727, and NFS, 0.733. The diagnostic performance of the ELF test, area under the curve, 0.820, was also superior to that of the FIB-4 index, 0.698, and NFS, 0.700, in patients with T2DM. With the low cutoff values for each non-invasive test, the ELF test provided an acceptable false negative rate, cutoff value 9.8, 6.7%, in this population, unlike the FIB-4 index, 1.30, 14.5%, and NFS, -1.455, 12.4%. After propensity score matching to avoid selection bias including age, sex, body mass index, and the prevalence of advanced fibrosis, the ELF test with a low cutoff value showed a high sensitivity, greater than or equal to 91.4%, and a high negative predictive value, greater than or equal to 96.8%, irrespective of the presence or absence of T2DM. Conclusions. The high diagnostic performance of the ELF test for predicting advanced fibrosis in individuals with or without T2DM could address an unmet medical need for accurate assessment of liver fibrosis in patients with diabetes and NAFLD. Histologic activity in inflammatory bowel disease and risk of serious infections, a nationwide study. Background and aims. Individuals with inflammatory bowel disease, IBD, are at increased risk of serious infections, but whether this risk varies by histologic disease activity is unclear. Methods. This was a national population-based study of 55,626 individuals diagnosed with IBD in 1990 to 2016 with longitudinal data on ileocolorectal biopsy specimens followed up through 2016. Serious infections were defined as having an inpatient infectious disease diagnosis in the Swedish National Patient Register. We used Cox regression to estimate hazard ratios, HRs, for serious infections in the 12 months after documentation of histologic inflammation versus histologic remission, adjusting for social and demographic factors, chronic comorbidities, prior IBD-related surgery, and hospitalization. We also adjusted for IBD-related medications and sensitivity analyses. Results. With histologic inflammation versus remission, there was 4.62, 95% C, 4.46 to 4.78, and 2.53, 95% C, 2.36 to 2.70, serious infections per 100 person-years of follow-up, respectively, adjusted HR, R, 1.59, 95% C, 1.48 to 1.72. Histologic inflammation versus remission was associated with an increased risk of serious infections and ulcerative colitis, R, 1.68, 95% C, 1.51 to 1.87, and Crohn's disease, R, 1.59, 95% C, 1.40 to 1.80. The Rs of sepsis and opportunistic infections were 1.66, 95% C, 1.28 to 2.15, and 1.71, 95% C, 1.22 to 2.41, respectively. Overall, results were consistent across age groups, sex, and education level, and remained largely unchanged after adjustment for IBD-related medications, R, 1.47, 95% C, 1.34 to 1.61. Conclusions. Histologic inflammation of IBD was an independent risk factor of serious infections, including sepsis, suggesting that achieving histologic remission may reduce infections in IBD. The diagnostic performance of fecal immunochemical tests for detecting advanced neoplasia at surveillance colonoscopy. Background and aims. An increasing burden on healthcare resources has resulted in a backlog of individuals requiring colonoscopy, with delays in surveillance possibly detrimental for individuals at increased risk of colorectal cancer, CRC. This study investigated the use of a two-sample fecal immunochemical test, FIT, to establish those most likely to have advanced neoplasia, and in need of prioritized surveillance colonoscopy. Methods. This was a prospective study conducted in the tertiary care setting. Participants completed a two-sample FIT, OC sensor, Aiken Chemical Company, within 90 days of surveillance colonoscopy. The sensitivity of FIT for detection of an CRC or advanced adenoma in moderate and high-risk individuals was determined at fecal hemoglobin thresholds between 2 and 80 g/g feces. Results. A total of 766 patients were included, median age, 66.1 years, interquartile range, 58.1 to 72.9, 49.9% male, with undetected in 8.6%, 66,766, including 5 CRC. For moderate risk individuals, with prior history of adenoma or a significant family history of CRC, sensitivity of FIT for an ranged from 73.5% at 2 g/g feces to 10.2% at 80 g/g feces. For high-risk conditions, confirmed/suspected genetic syndromes or prior CRC, sensitivity of FIT was similar, ranging from 70.6% at the lowest positivity threshold of 2 g/g feces to 11.8% at 80 g/g feces. Independent variables in the whole cohort for association with detection of an at surveillance colonoscopy were age, odds ratio, 1.03, 95% confidence interval, 1.00 to 1.06, and FIT hemoglobin result greater than or equal to 10 micrograms/g feces, odds ratio, 1.81, 95% confidence interval, 1.04 to 3.16. Conclusions. The use of FIT before surveillance colonoscopy provides clinicians with insights into the risk of an. This raises the possibility of a method to triage individuals, facilitating the more efficient management of endoscopic resources. Next, we will be discussing articles from Clinical Infectious Diseases. Clinical outcomes of patients with non-typhoidal salmonella infections by isolate resistance, foodborne diseases active surveillance network, 10 U.S. sites, 2004 to 2018. Background. Non-typhoidal salmonella causes an estimated 1.35 million U.S. infections annually. Antimicrobial resistant strains are a serious public health threat. We examine the association between resistance and the clinical outcomes of hospitalization, length of stay greater than or equal to 3 days, and death. Methods. We linked epidemiologic data from the Foodborne Diseases Active Surveillance Network with antimicrobial resistance data from the National Antimicrobial Resistance Monitoring System, NARMS, for non-typhoidal salmonella infections from 2004 to 2018. We defined any resistance as resistance to greater than or equal to 1 antimicrobial and clinical resistance as resistance to ampicillin, azithromycin, ceftriaxone, ciprofloxacin, or trimethoprim sulfamethoxazole, for the subset of isolates tested for all 5 agents. We compared outcomes before and after adjusting for age, state, race/ethnicity, international travel, outbreak association, and isolate serotype and source. Results. 20% of isolates, 1,105 5,549, had any resistance, and 16%, 469 2,969, had clinical resistance. Persons whose isolates had any resistance were more likely to be hospitalized, 31% versus 28%, p equals 0.01, or have length of stay greater than or equal to 3 days, 20% versus 16%, p equals 0.01. Deaths were rare but more common among those with any than no resistance, 1.0% versus 0.4%, p equals 0.01. Outcomes for patients whose isolates had clinical resistance did not differ significantly from those with no resistance. After adjustment, any resistance, adjusted odds ratio 1.23, 95% confidence interval 1.04 to 1.46, remained significantly associated with hospitalization. Conclusions. We observed a significant association between non-typhoidal salmonella infections caused by resistant pathogens and likelihood of hospitalization. Clinical resistance was not associated with poorer outcomes, suggesting that factors other than treatment failure, e.g., strain virulence, strain source, host factors, may be important. Clinical impact of multiplex molecular diagnostic testing in children with acute gastroenteritis presenting to an emergency department, a multi-center prospective study. Background: multiplex molecular diagnostic panels have greatly enhanced detection of gastrointestinal pathogens. However, data on the impact of these tests on clinical and patient-centered outcomes are limited. Methods: we conducted a prospective, multi-center, step-wedge trial to determine the impact of multiplex molecular testing at 5 academic children's hospitals on children presenting to the emergency department with acute gastroenteritis. Caregivers were interviewed on enrollment and 7 to 10 days after enrollment to determine symptoms, risk factors, subsequent medical visits, and impact on family members. During the pre-intervention period, diagnostic testing was performed at the clinician's discretion. During the intervention period, multiplex molecular testing was performed on all children, with results available to clinicians. The primary outcome was return visits to a healthcare provider within 10 days of enrollment. Results: potential pathogens were identified by clinician-ordered tests in 19 of 571, 3.3%, in the pre-intervention period compared with 434 of 586, 74%, in the intervention period. Clinically relevant pathogens were detected in 2.1% and 15%, respectively. In the multivariate model, the intervention was associated with a 21% reduction in the odds of any return visit, odds ratio 0.79, 95% confidence interval 0.70. 90, after adjusting for potential confounders. Appropriate treatment was prescribed in 11.3% compared with 19.6% during the intervention period, p equals 0.22. Conclusions: routine molecular multiplex testing for all children who presented to the ED with acute gastroenteritis detected more clinically relevant pathogens and led to a 21% decrease in return visits. Additional research is needed to define patients most likely to benefit from testing. Timing and predictors of loss of infectivity among healthcare workers with mild primary and recurrent COVID-19, a prospective observational cohort study. Background: there is a need to understand the duration of infectivity of primary and recurrent coronavirus disease 2019, COVID-19, and identify predictors of loss of infectivity. Methods: prospective observational cohort study with serial viral culture, rapid antigen detection test, RADT, and reverse transcription polymerase chain reaction, RT-PCR, on nasopharyngeal specimens of healthcare workers with COVID-19. The primary outcome was viral culture positivity as indicative of infectivity. Predictors of loss of infectivity were determined using multivariate regression model. The performance of the U.S. Centers for Disease Control and Prevention, CDC, criteria, fever resolution, symptom improvement, and negative ROT, to predict loss of infectivity was also investigated. Results: in total, 121 participants, 91 female, 79.3%, average age, 40 years, were enrolled. Most, N equals 107, 88.4%, had received greater than or equal to 3 severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, vaccine doses, and 20, 16.5%, had COVID-19 previously. Viral culture positivity decreased from 71.9%, 87-121, on day 5 of infection to 18.2%, 22-121, on day 10. Participants with recurrent COVID-19 had a lower likelihood of infectivity than those with primary COVID-19 at each follow-up, day 5 odds ratio, or 0.14, p less than 0.001, day 7 or 0.04, p equals 0.003, and were all non-infective by day 10, p equals 0.02. Independent predictors of infectivity included prior COVID-19, adjusted or AOR, on day 5, 0.005, p equals 0.003, and RT-PCR cycle threshold, CT, value less than 23, AOR on day 5, 22.75, p less than 0.001, but not symptom improvement or ROT result. The CDC criteria would identify 36%, 2467, of all non-infectious individuals on day 7. However, 17%, 529, of those meeting all the criteria had a positive viral culture. Conclusions: infectivity of recurrent COVID-19 is shorter than primary infections. Loss of infectivity algorithms could be optimized. Next, we will be discussing articles from Journal of Infectious Diseases. The effects of human immunodeficiency virus type 1, HIV-1, antigen-expanded specific T-cell therapy and vorinostat on persistent HIV-1 infection in people with HIV on antiretroviral therapy. Background: the histone deacetylase inhibitor vorinostat, VOR, can reverse human immunodeficiency virus type 1, HIV-1, latency in vivo, and allow T cells to clear infected cells in vitro. HIV-specific T cells, HXTCs, can be expanded ex vivo and have been safely administered to people with HIV, PWH, on antiretroviral therapy. Methods: 6 PWH received infusions of 2 × 107 HXTCs per square meter with 400 mg, and 3 PWH received infusions of 10 × 107 HXTCs per square meter with 4. The frequency of persistent HIV by multiple assays including quantitative viral outgrowth assay, QVOA, of resting CD4 plus T cells was measured before and after study therapy. Results: VOR in HXTCs were safe, and biomarkers of serial VOR effect were detected, but enhanced antiviral activity in circulating cells was not evident. After 2 × 107 HXTCs per square meter with VOR, 1 of 6 PWH exhibited a decrease in QVOA, and all 3 PWH exhibited such declines after 10 × 107 HXTCs per square meter in VOR. However, most declines did not exceed the 6-fold threshold needed to definitively attribute decline to the study intervention. Conclusions: these modest effects provide support for the strategy of HIV latency reversal and reservoir clearance, but more effective interventions are needed to yield the profound depletion of persistent HIV likely to yield clinical benefit. Next, we will be discussing articles from Arthritis and Rheumatology. Towards the lowest efficacious dose, results from a multi-center non-inferiority randomized open-label controlled trial assessing tocilizumab or abatacept injection spacing in rheumatoid arthritis in remission. Objective: we assess the clinical and structural impact at 2 years of progressively spacing tocilizumab, TCZ, or abatacept, ABA, injections versus maintenance at full dose in patients with rheumatoid arthritis in sustained remission. Methods: this multi-center open-label non-inferiority (NIE) randomized clinical trial included patients with established rheumatoid arthritis in sustained remission receiving ABA or TCZ as stable dose. Patients were randomized to treatment maintenance (M) at full dose (M arm) or progressive injection spacing (S), driven by the disease activity score in 28 joints every 3 months up to biologics discontinuation (S arm). The primary endpoint was the evolution of disease activity according to the disease activity score in 44 joints during the 2-year follow-up, analyzed per protocol with a linear mixed effects model, evaluated by a NIE test based on the one-sided 95% confidence interval, 95% C, of the slope difference, NIE margin 0.25. Other endpoints were flare incidence and structural damage progression. Results: overall, 202 of the 233 patients included were considered for per-protocol analysis, 90 in S arm and 112 in N arm. At the end of follow-up, 16.2% of the patients in the S arm could discontinue their biologic disease-modifying antirheumatic drug, 46.9% tapered the dose, and 36.9% returned to a full dose. NIE was not demonstrated for the primary outcome, with a slope difference of 0.10, 95% C 0.10 to 0.31, between the 2 arms. NIE was not demonstrated for flare incidence, difference 42.6%, 95% C 30.0 to 55.1, or rate of structural damage progression at 2 years, difference 13.9%, 95% C minus 6.7 to 34.4. Conclusion: The towards the lowest efficacious dose trial failed to demonstrate need for the proposed ABA or TCZ tapering strategy. Next, we will be discussing articles. American College of Cardiology. Preventive coronary intervention on stenosis with functionally insignificant vulnerable plaque. The PREVENT trial showed that preventive PCI of focal non-FFR positive plaques that are angiographically greater than 50% and have evidence of vulnerability on intravascular imaging along with OMT is superior to OMT for clinical outcomes at 2 years. Description: the goal of the trial was to compare the safety and efficacy of medical therapy along with focal preventive percutaneous coronary intervention, PCI, of non-flow limiting vulnerable plaque compared with medical therapy alone. Study design: patients were randomized in a 1-to-1 open-label fashion to either preventive PCI plus optimal medical therapy, OMT, N equals 803, or OMT alone, N equals 803. Total randomized participants, 1,606. Median duration of follow-up, 7 years. Median patient age, 64.5 years. Percentage female, 27%. Percentage with diabetes, 31%. Inclusion criteria: age greater than or equal to 18 years. Undergoing coronary angiography for stable ischemic heart disease, SIHD, or acute coronary syndrome. Coronary stenosis, greater than 50%, with negative fractional flow reserve, FFR, greater than or equal to 0.80, and meeting 2 of the following: imaging-defined vulnerable plaque. Minimal lumen area, MLA, less than or equal to 4.0 square millimeters. Plaque burden greater than 70%. Thin cap fibroadenoma by optical coherence tomography, OCT, or radiofrequency intravascular ultrasound, IVUS lipid-rich plaque by near-infrared spectroscopy, maxilliform greater than 315. Exclusion criteria: previous coronary artery bypass grafting. Target lesion previously stented. Greater than or equal to 3 target lesions in same patient, or greater than or equal to 2 target lesions in same vessel. Heavily calcified or angulated lesions. Bifurcation lesion requiring 2-stent technique. Principal findings: the primary endpoint of target vessel failure at 2 years, composite of death from cardiac causes, target vessel myocardial infarction, TVMI, ischemia-driven target vessel revascularization, IDTLR, or hospitalization for unstable or progressive angina, for PCI plus OMT versus OMT alone, was 0.4% versus 3.4%, hazard ratio, HR, 0.11, 95% confidence interval C 0.03 to 0.36, P equals 0.0003. Target vessel failure at 7 years, 6.5% versus 9.4%, HR 0.54, 95% C 0.33 to 0.87, P equals 0.0097. Key secondary outcomes for PCI plus OMT versus OMT. All-cause mortality at 2 years, 0.5% versus 1.3%, P greater than 0.05. All-cause mortality at 7 years, 5.2% versus 7.4%, P greater than 0.05. ALMI at 2 years, 1.1% versus 1.7%, P greater than 0.05. ALMI at 7 years, 2.4% versus 3.5%, P greater than 0.05. IDTLR at 2 years, 0.1% versus 2.4%, P less than 0.05. IDTLR at 7 years, 4.9% versus 8.0%, P less than 0.05. All-cause mortality or TVMI at 2 years, 0.6% versus 1.9%, P less than 0.05. All-cause mortality or TVMI at 7 years, 6.2% versus 8.6%, P greater than 0.05. Next, we will be discussing articles from journals of the American College of Cardiology. Water conservation overrides osmotic diuresis during SGLT2 inhibition in patients with heart failure. Background: sodium glucose cotransporter 2 inhibitors are believed to improve cardiac outcomes due to their osmotic diuretic potential. Objectives: the goal of this study was to test the hypothesis that vasopressin-driven urine concentration overrides the osmotic diuretic effect of glucosuria induced by dapagliflozin treatment. Methods: DAPA Shuttle 1, hepatorenal regulation of water conservation in heart failure patients with SGLT2 inhibitor treatment, was a single-center, double-blind, randomized, placebo-controlled trial, in which patients with chronic heart failure NYHA functional classes I/II and reduced ejection fraction were randomly assigned to receive dapagliflozin 10 mg daily or placebo, 1:1, for 4 weeks. The primary endpoint was change from baseline in urine osmolyte concentration. Secondary endpoints included changes in copeptin levels and solute-free water clearance. Results: 33 randomized, sodium glucose cotransporter 2 inhibitor naive participants completed the study, 29 of whom, placebo, N equals 14, dapagliflozin, N equals 15, provided accurate 24-hour urine collections, mean age 59 plus or minus 14 years, left ventricular ejection fraction 31% plus or minus 9%. Dapagliflozin treatment led to an isolated increase in urine glucose excretion by 3.3 mmol/kg/d, 95% C, 2.51 to 4.04, p less than 0.0001, within 48 hours, early, which persisted after 4 weeks, late, 2.7 mmol/kg/d, 95% C, 1.98 to 3.51, p less than 0.0001. Dapagliflozin treatment increased serum copeptin early, 5.5 mol/L, 95% C, 0.45 to 10.5, p less than 0.05, and late, 7.8 mol/L, 95% C, 2.77 to 12.81, p less than 0.01, leading to proportional reductions in free water clearance, early, minus 9.1 milliliters/kg/d, 95% C, minus 14 to minus 4.12, p less than 0.001, late, minus 11.0 milliliters/kg/d, 95% C, minus 15.94 to minus 6.07, p less than 0.0001, and elevated urine concentrations, late, 134 mmol/L, 95% C, 39.28 to 229.12, p less than 0.01. Therefore, urine volume did not significantly increase with dapagliflozin, mean difference early, 2.8 milliliters/kg/d, 95% C, minus 1.97 to 7.48, p equals 0.25, mean difference late, 0.9 milliliters/kg/d, 95% C, minus 3.83 to 5.62, p equals 0.70. Conclusions: physiological adaptive water conservation eliminated the expected osmotic diuretic potential of dapagliflozin and thereby prevented a glucose-driven increase in urine volume of approximately 10 milliliters/kg/d. Middle. 75 kilograms equals 750 milliliters/kg/d. Hepatorenal regulation of water conservation in heart failure patients with SGLT2 inhibitor treatment. Next, we will be discussing articles from Journal of Clinical Endocrinology and Metabolism. Discontinuation of drug treatment in Cushing's disease not cured by pituitary surgery. Objective: when transsphenoidal surgery, TSS, does not cure Cushing's disease, CD, 4 treatments are available: drug treatment, DT, second TSS, bilateral adrenalectomy, BA, and pituitary radiotherapy, PR. DT is attractive but supposes long-term continuation, which we aim to evaluate. Design and methods. Retrospective study, in a center prioritizing second TSS, of 36 patients, including 19 with TSS failure and 17 with recurrence, out of 119 patients with CD treated by a first TSS, average follow-up 6.1 years, 95% confidence interval 5.27 to 6.91. Control was defined as normalization of urinary free cortisol, UFC, and final treatment, FT, as the treatment allowing control at last follow-up. We also analyzed discontinuation rates of DT in published CD prospective clinical trials. Results. Control was achieved in 33-36 patients, 92%. DT was initiated in 29-36 patients, 81%, allowing at least one normal UFC in 23-29 patients, 79%, but was discontinued before last follow-up in 18-29 patients, 62%. DT was FT in 11-29 patients, 38%, all treated with cortisol synthesis inhibitors. Second TSS was FT in 8/16, 50%, BA in 14-14, 100%, and PR in 0.5. In published trials, discontinuation of DT was 11% to 51% at 1 year and 32% to 74% before 5 years. Conclusion. DT allowed at least one normal UFC in 23-29 patients, 79%, but obtained long-term control in only 11-29, 38%, as discontinuation rate was high, although similar to published data. Interestingly, a successful second TSS was the cause for discontinuing efficient and well-tolerated DT in 5 patients. Further studies will show whether different strategies with cortisol synthesis inhibitors may allow for a lower discontinuation rate in patients not candidates for a second TSS, so that BA may be avoided in these patients. Dasiglucagon for the treatment of congenital hyperinsulinism, a randomized phase 3 trial in infants and children. Context. Congenital hyperinsulinism, CHI, is characterized by dysregulated insulin secretion causing hypoglycemia and consequent brain damage. Dasiglucagon is a glucagon analog under investigation to treat CHI. Objective: to evaluate the efficacy and safety of dasiglucagon delivered via continuous subcutaneous infusion to children with CHI and persistent hypoglycemia as add-on to standard of care, SOC. Methods. In this open-label trial, patients were randomized 1:1 to SOC or SOC plus dasiglucagon, 10 to 70 micrograms/H, for 4 weeks. In the following 4 weeks, all patients received dasiglucagon plus SOC. Hypoglycemia was assessed by self-monitored plasma glucose, SMPG, and blinded continuous glucose monitoring, CGM. Primary endpoint was average number of SMPG detected hypoglycemia episodes/week, SMPG less than 3.9 mol/L, during weeks 2 to 4. Results. 32 patients, 0.6 to 10.9 years, were randomly assigned to dasiglucagon plus SOC, N equals 16, or SOC, N equals 16. The rate of SMPG detected hypoglycemia decreased from baseline in both groups, but with no statistically significant difference during weeks 2 to 4. Event rate ratio 0.85, 0.54, 1.36, p equals 0.5028. However, dasiglucagon administration resulted in a 43% reduction in CGM detected hypoglycemia, less than 3.9 mol/L, versus SOC alone during weeks 2 to 4. Post hoc analysis, event rate ratio 0.57, 0.39, 0.83, p equals 0.0029. Dasiglucagon enabled reductions of 37% to 61% in all other measures of hypoglycemia assessed by CGM versus SOC alone, including extent and percent time in hypoglycemia. Post hoc analysis. Dasiglucagon appeared safe and well tolerated. Skin and gastrointestinal events were more frequent with dasiglucagon plus SOC than SOC only. Conclusion. Clinically meaningful reductions in all CGM recorded measures of hypoglycemia support using dasiglucagon as a potential treatment for CHI. Next, we will be discussing articles from Neurology. Trends in cognitive function before and after diabetes onset, the China Health and Retirement Longitudinal Study. Background and objectives. Individuals with prevalent diabetes were known to have a higher risk of dementia and lower cognitive function. However, trends of cognitive function before diabetes and in the short term after new onset diabetes remain unclear. Methods. This study included participants without baseline diabetes from the China Health and Retirement Longitudinal Study. Cognitive tests were conducted at baseline, Wave 1, and at least one time from Wave 2, 2013, to Wave 4, 2018. Cognitive function was assessed using a global cognition score, which was the summary measure of 4 cognitive tests. A linear mixed model was constructed to fit the trends in cognitive function before and after diabetes onset and the trends among non-diabetes. The threshold of statistical significance was p less than 0.05. Results. During the 7-year follow-up, 1,207, 9.7% of 12,422, 59.1 plus or minus 8.6 years, 39.9% male participants developed new onset diabetes. The cognitive function of both the without diabetes group and the diabetes group declined annually during the follow-up. The annual decline rate of the diabetes group before diabetes onset was similar to that of the without diabetes group during the whole follow-up period. After diabetes onset, participants experienced statistically significant faster cognitive declines in global cognition, minus 0.023 SD/year, 95% C minus 0.043 to minus 0.004, P equals 0.019, and visuospatial abilities test, minus 0.036 SD/year, minus 0.061 to minus 0.011, P equals 0.004, but not in tests of episodic memory, minus 0.018 SD/year, minus 0.041 to 0.004, P equals 0.116, attention and calculation, minus 0.017 SD/year, minus 0.037 to 0.003, P equals 0.090 or orientation, 0.001 SD/year, minus 0.018 to 0.020, P equals 0.894, compared with the cognitive slope before diabetes. In subgroup analysis, compared with those who developed diabetes between 45 to 54 years, those developing diabetes older, 55 to 64 years, P for interaction equals 0.701, 65 to 74 years, P for interaction equals 0.996, did not demonstrate different rates of global cognitive decline after diabetes. Discussion. Individuals experienced faster rate of cognitive decline in a few years after diabetes onset, but not during the pre-diabetes period. Age did not modify the effect of diabetes on post-diabetes cognitive decline. Efforts in eliminating the adverse impacts on cognition should be started on diagnosis of diabetes. Statin therapy for secondary prevention in ischemic stroke patients with cerebral microbleeds. Background and objectives. The association between statin use and the risk of intracranial hemorrhage, ICR, following ischemic stroke, is, or transient ischemic attack, TIA, in patients with cerebral microbleeds, CMBs, remains uncertain. This study investigated the risk of recurrent IS and ICR in patients receiving statins based on the presence of CMBs. Methods. We conducted a pooled analysis of individual patient data from the Microbleeds International Collaborative Network, comprising 32 hospital-based prospective studies fulfilling the following criteria: adult patients with IS or TIA, availability of appropriate baseline MRI for CMB quantification and distribution, registration of statin use after the index stroke, and collection of stroke event data during a follow-up period of greater than or equal to 3 months. The primary endpoint was the occurrence of recurrent symptomatic stroke, IS or ICR, while secondary endpoints included IS alone or ICR alone. We calculated incidence rates and performed Cox regression analyses adjusting for age, sex, hypertension, atrial fibrillation, previous stroke, and use of antiplatelet or anticoagulant drugs to explore the association between statin use and stroke events during follow-up in patients with CMBs. Results. In total, 16,373 patients were included, mean age 70.5 plus or minus 12.8 years, 42.5% female. Among them, 10,812 received statins at discharge, and 4,668 had one or more CMBs. The median follow-up duration was 1.34 years, interquartile range, 0.32 to 2.44. In patients with CMBs, statin users were compared with non-users. Compared with non-users, Statin therapy was associated with a reduced risk of any stroke. Incidence rate, IR, 53 versus 79 per 1,000 patient years. Adjusted hazard ratio, R, 0.68, 95% C 0.56 to 0.84. A reduced risk of IS, IR 39 versus 65 per 1,000 patient years, R 0.65, 95% C 0.51 to 0.82, and no association with the risk of ICUR, IR 11 versus 16 per 1,000 patient years, R 0.73, 95% C 0.46 to 1.15. The results in A remained consistent when considering anatomical distribution and high burden greater than or equal to 5 of CMBs. Discussion. These observational data suggest that secondary stroke prevention with statins in patients with IS or TIA and CMBs is associated with a lower risk of any stroke or IS without an increased risk of ICUR. Next, we will be discussing articles from CHEST. Longitudinal effects of elexacaftor/tezacaftor/ivacaftor. Background. Italy initiated elexacaftor/tezacaftor/ivacaftor, ETI, for people with cystic fibrosis, PWCF, in July 2021. It has led to dramatic improvements in lung function, BMI, sweat chloride, and respiratory symptoms. However, few data are available on side effects or effects on a broad range of outcomes. Research question. How does ED affect mental health, cognitive processing, neuropsychological side effects, GI symptoms, and health-related quality of life over time? Study design and methods. This was a prospective, real-world longitudinal study. Participants were recruited consecutively and evaluated at initiation, T0, and after 1 month, 3 months, and 6 months of starting treatment. Assessments included depression, 9-item patient health questionnaire, anxiety, 7-item generalized anxiety disorder, cognition, symbol-digit modalities test, GI symptom tracker, and health-related quality of life, cystic fibrosis questionnaire revised. Based on literature, an ad hoc questionnaire was developed to assess side effects, insomnia, headache, memory problems, brain fog, and concentration problems. Following descriptive analyses, longitudinal data were analyzed by using mixed models for repeated measures, controlling for age and sex when appropriate. Results. 92 consecutive PWCF, female/male, 46-46, mean age, 25.4 years, participated. FEV1 increased initially and then remained stable. BMI also increased significantly from T0 to 6 months, p less than 0.01. Depression improved from T0 to 1 month, p less than 0.001, however, no changes in anxiety were found. Cognitive processing improved from T0 to subsequent assessments. Positive changes were reported on the GI symptom tracker for stools and adherence challenges, although no changes were found for abdominal pain and digestion. Side effects occurred in 10% to 29%, with no reduction over time. Insomnia increased significantly across time. Female participants reported more side effects than male participants: insomnia, headache, concentration problems, brain fog. Interpretation. This prospective study evaluated the effects of ED using multiple measures. Significant improvements were found in many domains. However, side effects were reported by a substantial proportion of PWCF, with no improvements over time. Female participants reported more side effects than male participants. PWCF should be followed up systematically to assess the frequency of side effects after starting this new modulator. Etiology-based prognosis of extracorporeal CPR recipients after out-of-hospital cardiac arrest. Background. A better understanding of the relative contributions of various factors to patient outcomes is essential for optimal patient selection for extracorporeal CPR, eCPR, therapy for patients with out-of-hospital cardiac arrest, OHCA. However, evidence on the prognostic comparison based on the etiologies of cardiac arrest is limited. Research question. What is the etiology-based prognosis of patients undergoing eCPR for OCA? Study design and methods. This retrospective multi-center registry study involved 36 institutions in Japan and included all adult patients with OCA who underwent ECPR between January 2013 and December 2018. The primary etiology for OCA was determined retrospectively from all hospital-based data at each institution. We performed a multivariable logistic regression model to determine the association between etiology of cardiac arrest and two outcomes: favorable neurologic outcome and survival at hospital discharge. Results: we identified 1,781 eligible patients, of whom 1,405, 78.9%, had cardiac arrest because of cardiac causes. Multivariable logistic regression analysis for favorable neurologic outcome showed that accidental hypothermia, adjusted OR, 5.12, 95% C, 2.98 to 8.80, p less than 0.001, was associated with a significantly higher rate of favorable neurologic outcome than cardiac causes. Multivariable logistic regression analysis for survival showed that accidental hypothermia, adjusted OR, 5.19, 95% C, 3.15 to 8.56, p less than 0.001, had significantly higher rates of survival than cardiac causes. Acute aortic dissection/aneurysm, adjusted OR, 0.07, 95% C, 0.02 to 0.28, p less than 0.001, and primary cerebral disorders, adjusted OR, 0.12, 95% C, 0.03 to 0.50, p equals 0.004, had significantly lower rates of survival than cardiac causes. Interpretation: in this retrospective multi-center cohort study, although most patients with OCA underwent ECPR for cardiac causes, accidental hypothermia was associated with favorable neurologic outcome and survival. In contrast, acute aortic dissection/aneurysm and primary cerebral disorders were associated with non-survival compared with cardiac causes. Hospital policy variation in addressing decisions to withhold and withdraw life-sustaining treatment. Background: sociodemographic disparities in physician decisions to withhold and withdraw life-sustaining treatment exist. Little is known about the content of hospital policies that guide physicians involved in these decisions. Research question: what is the prevalence of U.S. hospitals with policies that address withholding and withdrawing life-sustaining treatment? How do these policies approach ethically controversial scenarios, and how do these policies address sociodemographic disparities in decisions to withhold and withdraw life-sustaining treatment? Study design and methods. This national cross-sectional survey assessed the content of hospital policies addressing decisions to withhold or withdraw life-sustaining treatment. We distributed the survey electronically to American Society for Bioethics and Humanities members between July and August 2023 and descriptively analyzed responses. Results: among 93 respondents from hospitals or hospital systems representing all 50 U.S. states, Puerto Rico, and Washington, D.C., 92% had policies addressing decisions to withhold or withdraw life-sustaining treatment. Hospitals varied in their stated guidance, permitting life-sustaining treatment to be withheld or withdrawn in cases of patient or surrogate request, 82%, physiologic futility, 81%, and potentially inappropriate treatment, 64%. Of the 8% of hospitals with policies that address patient sociodemographic disparities in decisions to withhold or withdraw life-sustaining treatment, these policies provided opposing recommendations to either exclude sociodemographic factors in decision-making or actively acknowledge and incorporate these factors in decision-making. Only 3% of hospitals had policies that recommended collecting and maintaining information about patients for whom life-sustaining treatment was withheld or withdrawn that could be used to identify disparities in decision-making. Interpretation: although most surveyed U.S. hospital policies address withholding or withdrawing life-sustaining treatment, these policies varied widely in criteria and processes. Surveyed policies also rarely address sociodemographic disparities in these decisions. Next, we will be discussing articles from the American Journal of Respiratory and Critical Care Medicine. Heterogeneity of benefit from earlier time to antibiotics for sepsis. Rationale: shorter time to antibiotics improves survival from sepsis, particularly among patients in shock. There may be other subgroups for whom faster antibiotics are particularly beneficial. Objectives: identify patient characteristics associated with greater benefit from shorter time to antibiotics. Methods: observational cohort study of patients hospitalized with community-onset sepsis at 173 hospitals and treated with antimicrobials within 12 hours. We used 3 approaches to evaluate heterogeneity of benefit from shorter time to antibiotics. 1. Conditional average treatment effects of shorter, 3H, versus longer, greater than 3 to 12H, time to antibiotics on 30-day mortality using multivariable Poisson regression. 2. Causal forest to identify characteristics associated with greatest benefit from shorter time to antibiotics. And 3. Logistic regression with time to antibiotics modeled as a spline. Measurements and main results. Among 273,255 patients with community-onset sepsis, 131,094, 48.0%, received antibiotics within 3 hours. In Poisson models, shorter time to antibiotics was associated with greater absolute mortality reduction among patients with metastatic cancer, 5.0%, 95% confidence interval, c. 4.3 to 5.7, versus 0.4%, 95% c. 0.2 to 0.6, for patients without cancer, p less than 0.001, patients with shock, 7.0%, 95% c. 5.8 to 8.2%, versus 2.8%, 95% c. 2.7 to 3.5%, for patients without shock, p equals 0.005, and patients with more acute organ dysfunctions, 4.8%, 95% c. 3.9 to 5.6%, for 3 or more dysfunctions versus 0.5%, 95% c. 0.3 to 0.8, for 1 dysfunction, p less than 0.001. In causal forest, metastatic cancer and shock were associated with greatest benefit from shorter time to antibiotics. Spline analysis confirmed differential nonlinear associations of time to antibiotics with mortality in patients with metastatic cancer and shock. Conclusions: in patients with community-onset sepsis, the mortality benefit of shorter time to antibiotics varied by patient characteristics. These findings suggest that shorter time to antibiotics for sepsis is particularly important among patients with cancer and/or shock. Next we will be discussing articles is from Clinical Journal of American Society of Nephrology. Association of bioimpedance parameters with increases in blood pressure during hemodialysis. Background: intradialytic hypertension, defined as an increase in BP from pre to post hemodialysis, HT, affects 5% to 15% of patients receiving maintenance HT and is associated with cardiovascular and all-cause mortality. Hypervolemia is believed to be a major etiological factor, yet the association of more objective biomarkers of volume status with intradialytic hypertension is not well described. Methods: in a post-hoc analysis of the frequent hemodialysis network daily trial, N equals 234, using data from baseline, 1, 4, and 12-month visits, N equals 800, we used random effects regression to assess the association of bioimpedance estimates of volume, vector length, with post-HD systolic BP, continuous, and any increase in systolic BP, categorical, from pre to post-HD. We adjusted models for randomized group, age, sex, self-reported race, Kitley body mass index, vascular access, HD vintage, hypertension, history of heart failure, diabetes, residual kidney function, urea clearance, pre-HD systolic BP, ultrafiltration rate, serum dialysate sodium gradient, and baseline values of hemoglobin, phosphate, and equilibrated KT/V urea. Results: the mean age of participants was 50 plus or minus 14 years, 39% were female, and 43% were Black. In adjusted models, shorter vector length, per 50 ohm/m, was associated with higher post-HD systolic BP, 2.9 mm Hg, 95% confidence interval, c. 1.6 to 4.3, and higher odds of intradialytic hypertension, odds ratio 1.66, 95% c. 1.07 to 2.55. Similar patterns of association were noted with a more stringent definition of intradialytic hypertension, greater than 10 mm Hg increase from pre to post HD systolic BP, where shorter vector length, per 50 ohm/m, was associated with a higher odds of intradialytic hypertension, odds ratio 2.17, 95% C, 0.88 to 5.36. Conclusions. Shorter vector length, a bioimpedance-derived proxy of hypervolemia, was independently associated with higher post-HD systolic BP and risk of intradialytic hypertension. Drug-coated balloon angioplasty for dysfunctional arteriovenous hemodialysis fistulae, a randomized controlled trial. Background. The aim of this study was to evaluate the efficacy and safety of paclitaxel-coated balloons, A.I.O. Art-Orchid, in treating dysfunctional arteriovenous fistulae. Methods. The drug-eluting balloon for arteriovenous (AV) fistula in China trial was a prospective, multi-center, randomized controlled study. Patients who had greater than or equal to 50% venous stenosis of the AV fistula and symptoms indicating significant hemodynamic changes were included. After successful predilation with a high-pressure balloon, residual stenosis less than or equal to 30%, patients were randomized 1:1 to either a paclitaxel-coated balloon or an uncoated control balloon. The primary efficacy outcome was assessed at 6 months, and safety assessment was conducted within 30 days of the procedure. The 12-month results were also analyzed. Results. The study included 244 patients, equally distributed between the two groups. The primary target lesion patency was 91%, 106-116 for the drug-coated balloon, DCB, group and 67%, 79-118 for the plain balloon catheter group, representing a difference of 24.63%, 95% confidence interval, 14.68 to 34.58, p less than 0.001. The secondary efficacy endpoint was primary target lesion patency at 12 months, which was 66%, 74-112, for the DCB group and 46%, 52-112, for the plain balloon catheter group, 95% confidence interval, 6.57 to 32.08, p equals 0.004. The mean number of reinterventions per patient to maintain target lesion patency during the 12 months after the index procedure was 0.39, 48-122, in the DCB group and 0.77, 94-122, in the plain balloon catheter group, p equals 0.001. The primary safety endpoint did not differ between groups, p equals 0.25. Conclusions. A.I.O. Art-Orchid DCB showed better primary patency rates compared with plain balloon angioplasty for treating stenotic lesions in dysfunctional hemodialysis AV fistulae at 6 and 12 months. It required fewer repeated interventions and had comparable safety in 1 year. Next we will be discussing articles is from Kidney International Reports. Patient Perspectives of Center-Specific Reporting in Kidney Failure Care, an Australian qualitative study. Introduction. Public reporting of quality of care indicators in healthcare is intended to inform consumer decision-making. However, people may be unaware that such information exists, or it may not capture their priorities. The aim of this study was to understand the views of people with kidney disease about public reporting of dialysis and transplant center outcomes. Methods. This qualitative study involved 27 patients with lived experience of kidney disease in Australia who participated in 11 online focus groups between August and December 2022. Transcripts were analysed thematically. Results. Patients from all Australian states and territories participated, with 22, 81%, having a functioning kidney transplant and 22, 81%, having current or previous experience of dialysis. 5 themes were identified as follows: I. Surrendering to the health system. 2. The complexity of quality. 3. Benefits for patient care and experience. 4. Concern about risks and unintended consequences. And B. Optimizing the impact of data. Conclusion. Patients desire choice among kidney services but perceive this as rarely possible in the Australian context. Health professionals are trusted to make decisions about appropriate centers. Public reporting of center outcomes may induce fear and a loss of balanced perspective. However, it was supported by all participants and represents an opportunity for self-advocacy and informed decision-making. Strategies to mitigate potential risks include availability of trusted clinicians and community members to aid in data interpretation, providing context about centers and patients, and framing statistics to promote positivity and hope. Features of postpartum hemorrhage-associated thrombotic microangiopathy and role of short-term complement inhibition. Introduction. In pregnancy-related atypical hemolytic uremic syndrome, POS, transferring recommendations for treatment decisions from non-pregnant cohorts with thrombotic microangiopathy, TMA, is difficult. Although potential causes of POS may be unrelated to inherent complement defects, peripartal complications such as postpartum hemorrhage, PPH, or preeclampsia or hemolysis, elevated liver enzymes and low platelets, HELP, syndrome may be unrecognized drivers of complement activation. Methods. To evaluate diagnostic and therapeutic decisions in the practical real-life setting, we conducted an analysis of a cohort of 40 patients from 3 German academic hospitals with a diagnosis of POS, stratified by the presence, n equals 25, or absence, n equals 15, of PPH. Results. Histological signs of TMA were observed in 84.2% of all patients, 100% versus 72.7% in patients without or with PPH, respectively. Patients without PPH had a higher likelihood, 20% versus 0%, of pathogenic genetic abnormalities in the complement system, although notably less than in other published cohorts. 4 of 5 patients with observed renal cortical necrosis, RCN, after PPH received complement inhibition and experienced partially recovered kidney function. Patients on complement inhibition with or without PPH had an increased need for kidney replacement therapy, KRT, and plasma exchange, PEX. Because renal recovery was comparable among all patients treated with complement inhibition, a potential beneficial effect in this group of pregnancy-associated TMAs and POS is presumed. Conclusion. Based on our findings, we suggest a pragmatic approach toward limited and short-term anticomplement therapy for patients with a clinical diagnosis of POS, which should be stopped once causes of TMA other than genetic complement abnormalities emerge. Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.